Well, good morning, everyone. Very happy and honored to be here. I've been at the University of North Dakota now just for about 6 months. Prior to that, I was at NDSU, but I serve as the Associate Dean for Diversity, Equity, and Inclusion at the medical school. I'm also Director of the Master Public Health Program and Director of what's called the Indians into Medicine Program, or InMed program, as well as Professor of Family and Community Medicine. So I've got 4 hats that I'm wearing while I'm at University of North Dakota. Prior to that, I was at NDSU for 7 years, and I was the initial Director of the Master Public Health Program there. And in my own experience, the need to integrate public health approaches, even within clinical medicine, are just tremendous. We know this in hospital settings where we're trying to manage preventable infectious disease that can be spread in the hospital. That really is a public health approach. But also when we look at issues related to suicide risk and other types of mental health considerations, we do need a broader public health approach, looking at what we can do to promote prevention as opposed to just treating issues after they become a crisis. Well, I'm Oglala Lakota, originally from Pine Ridge, South Dakota. And in my family, I appreciate those who have shared their own personal stories, Cora and Mylin, and the courage it takes to talk about these challenging stories. But in my own family, I lost an uncle as well as a nephew to suicide. And when I think about the devastation that occurs, not just for that individual, but for the entire family, and in many ways, the entire community, it really is tremendous. And what we need to do is prevent this from occurring in the first place. So in my own experience, I am a family doctor, and I've worked in a number of different settings over the years. And what I realize is that quite often people who are dealing with challenging mental health considerations are not plugged into the mental health services arena. But quite often they do have physical health problems, and they're going to see the primary care doctor, or they might have medical issues that require specialists to care for their physical health issues. But quite often they're not plugged into mental health. And what I noticed in my own practice is that quite often we do too much in the way of compartmentalizing. You know, there's mental health over there, and there's physical health over there. And when I was in my practice back in the 1990s, quite often all we would do is just a mental health referral, right? Hand them a slip to be referred. And that's not good enough. And in my own experience in clinical practice, we also saw a lot of people falling through the cracks. You know, it's not good enough to just say, here's your referral, now get over to the behavioral health center. We have to do a much better job at that. And over the years, I've been looking at different types of programs and different types of services that can do a better job of screening and intervention. And one of the better programs that I've seen is Zero Suicide. So I'll talk more about that. I'm so happy to see Prairie St. John really adopting this and implementing it in a very comprehensive way. It's exciting to see. My reason for being so interested in this as a family doctor is, of course, it's affected me personally and my family, but it's also affected my community tremendously. So we'll look at some American Indian suicide disparities and try to understand what is the basis for that. And when we think about medical care and mental health care, quite often we put those in their separate silos, don't we? We do a good job of compartmentalizing issues. But I think what we also need to realize is that there's multiple social factors, cultural factors, political factors, financial factors that have a huge impact on the mental health of a population. And if we're going to take a public health approach and look at an entire population, we have to recognize there are multiple inputs that are causing people to become suicidal. And there's some unique issues that we face in American Indian populations. I'll briefly touch on some of those today. I'll look at the Zero Suicide Program overview. Can't do it justice in a 1-hour discussion. It's really a 2-day training to get adequate Zero Suicide training. But just out of curiosity, how many people have been through Zero Suicide trainings? So only a handful. How many people have heard of Zero Suicide? Okay, that's good. That's encouraging. So at least we've heard of it now. And then I'll talk about the elements of Zero Suicide and just a brief discussion at the end. So why is this important for American Indian and Alaska Native communities? Nationally, the suicide rate for American Indians and Alaska Natives is about 4 times the national average. 4 times. It's just really remarkable. But the suicide disparity also occurs at a younger age. So we're seeing suicide in children in many cases. One of my cousins, when he was very young, he was only about 8 years old, he found his best friend who had hung himself. And he was only about 8 years old at that time. And that sent my cousin on a very terrible path. I think having that degree of an adverse childhood experience, being the one to discover his best friend at age 8 who had killed himself by hanging, devastated him, and it's had an impact for the rest of his life. He's had his own issues with substance abuse. He's had his own issues being in and out of prison, and much of this is related to that adverse experience of being the one to discover his friend who had killed himself. So we see this in younger ages as well within the American Indian population. So if we look at adolescents and young adults, the suicide rate is about 1.5 times greater than national average. This is data from the CDC. And this is looking at the percentages of people within each age group who did commit suicide. And you can see for American Indians and Alaska Natives, nearly 10% of the suicides are between age 10 and 17. Isn't that remarkable? So not only do we see a higher percentage of suicides within the population, we see it at a younger age. So the years of potential life lost are even greater than the actual disparity in overall suicides. So this is recent data from CDC, the most up-to-date data, but this has been an ongoing problem. Just looking at some of the old presentations I've done and the work that I've done, even going back 1990 through 2002, in North Dakota and South Dakota, the suicide rates are more than double for the American Indian population compared to the white population in both the Dakotas. And of course, I've been living and working here in North Dakota for over a decade, but I'm originally from South Dakota, and the populations deal with very similar issues, both with American Indian populations, but also rural populations. And we're starting to see increases in suicidality even among rural non-Indian populations, aren't we? This is becoming a big issue statewide. And as was shared earlier, in North Dakota, we've had the biggest increase in suicides. So something's happening here. There's some major issues that I think we're not addressing, certainly within the public health arena and identifying people at risk. But even those who are engaging the medical systems, we're not doing a good enough job of screening for risk. And when we look at high-risk populations, quite often it's also the populations that have the least access to services. We don't have psychiatrists in every county in North Dakota, do we? We have a huge shortage. And when we look at even just basic services and community health workers and being engaged in the community, I think one of our challenges is the social isolation that a lot of people are feeling. And I like the diagram with the components of feeling like they're burdensome, and then also feeling hopeless and helpless, and looking at that as part of the risk. But I really believe social isolation is one of our biggest risk factors. And I see that across populations, not just in American Indian populations, but social isolation, I think, is one of the things that's leading to these terrible increases in suicidality. And even though it's getting worse statewide, it's been consistently worse for American Indians in North Dakota. We see the same pattern in South Dakota. And again, look at those young ages. The disparity is worse overall, but particularly in younger ages. And we tend to see a spike of suicide in the American Indian population in the teenage years and early adulthood. And then it kind of tapers off as people go through life and get older. So why is that? Why do we have such a terrible disparity? And what are the things that we should think about doing to address the challenge? Well, when we look at the American Indian population by county, we can see that our population is concentrated primarily in the West, right? So we have significant American Indian and Alaska Native populations in Alaska, Montana, North Dakota, South Dakota, Arizona, New Mexico, and Oklahoma, and relatively few in the East. And is that because historically American Indians didn't like the East Coast? Too much traffic, so we just didn't live there, right? Well, there's actually a history that I think is largely misunderstood and largely ignored, quite honestly. And if we think of this from a holistic perspective, we have to recognize that there is an impact of history and policy on populations that are marginalized. And when we look at the American Indian Alaska Native population, going back to the time of discovery in 1492, it's estimated that in the Americas there were probably about 20 million indigenous people in North America and South America. And of that number, probably about 5 million who lived in what is now the United States. Little known fact, by 1900, the American Indian population got below 200,000. So it's almost a complete genocide. And when we look across populations that have suffered this type of genocide, we see higher rates of suicidality. This is a part of our history. This is a part of our history not just nationally, but also right here in North Dakota. And we have to recognize that there are unique histories across populations that require unique approaches. And we have to look at each population for the unique histories and unique cultures that they bring to the table, and not just take a one-size-fits-all approach to how we're addressing things like suicidality. So I've done a lot of work in this area, looking at the intergenerational basis for chronic disease disparities and certainly mental health disparities as well. And one of the things that I see is a strong linkage between chronic disease and depression. And I see, for example, in my own clinical practice, I'd seen hundreds of patients who had diabetes and very high rates of depression within the people who have diabetes. And what's the most common self-medication for depression in this country? Alcohol. Does alcohol intake worsen your blood sugar? Which worsens your depression? Which worsens your blood sugar? Which worsens your depression? Which worsens your, all of these things fall into a vicious cycle. And the problem is we haven't taken a holistic approach to this. We kind of, again, compartmentalize medical care and behavioral health care. Well, for American Indians, we have additional issues to consider. There's a lot of work being done in historical trauma, and that's looking at cataclysmic events that have occurred within populations and how those negative consequences can pass from one generation to the next. Some of the best research in this area has been with survivors of the Holocaust. And if you look at Jewish survivors and descendants of the Holocaust, and you have matched controls who were not directly involved in the Holocaust, the offspring of Holocaust survivors have worse health status and more suicidality than those who were not linked directly to the Holocaust. So we know there's some sort of epigenetic pattern that's occurring, passing risk for disease across generations. One of the other unique components of American Indian history, even right here in North Dakota, is the boarding school experiences. And you know, the boarding schools started back in the 1800s, but continued well into the mid-1900s as well. And my mother is a survivor of boarding schools. And there was all kinds of abuse that occurred. And when we look at an entire generation that was removed from their home, again, suffering from social isolation and, quite honestly, abuse and neglect, increased death rates for children who went to boarding schools, we see that passing on from generation to generation and the trauma that's linked to that. There's been a lot of work in recent years looking at adverse childhood experiences. Now, I would imagine that most of you are familiar with the ACE study, or Adverse Childhood Experiences study. And what they've shown in these studies repeatedly is that children who suffer adversity during childhood have much higher risk for chronic disease, for suicidality, for depression, for addiction. And unfortunately, when we look at what limited data are available in marginalized populations, including American Indians, we tend to see more adversity during childhood. So we see a lot of self-medication, and unfortunately, we also see increased rates of suicide in populations that have suffered tremendous adverse childhood experiences. So the theory is that with adverse childhood experiences, there's a disruption in neurological development that has an impact on behavior. And I'm sure many of us have seen this, that children who are living in dire circumstances and within a lot of dysfunction at home, they have behavioral challenges at school, don't they? They have behavioral challenges even keeping a job. So we see these challenges pile up. And then again, people self-medicate, and not just alcohol, right? There's other challenges related to opiates and methamphetamine. And our most common treatment for that type of addiction is incarceration, right? which only puts people at higher risk for suicidality. And when we think about the identified adverse childhood experiences, we have to recognize that having a parent who is incarcerated is an adverse childhood experience. So what we're doing is the survivors of high ACE scores eventually become addicted and have children, right? And then what do? We incarcerate them and pass that adverse childhood experience on to the next generation. We need to look at this in a much more holistic and intelligent way. We're not going to incarcerate our way out of addiction. That's been our approach, but it's not very smart. And if anything, we're making the challenges worse for subsequent generations. So when we look at suicidality, it's not within a silo, right? There are cultural factors, there are historical factors, there's issues related to trauma, issues related to general social determinants of health. So we have to, again, look at this from a more holistic perspective. And what we recognize is people with more adversity in childhood not only have higher rates of suicidality and chronic disease, we also see earlier death. And when I look at the list of disparities that are associated with adverse childhood experiences, it's essentially the list of American Indian health disparities that I observe. So again, we're not going to incarcerate our way out of this. In truth, we're not even going to prescribe our way out of this, right? Is there a pill that's going to fix unresolved trauma? Can I prescribe you something to take to the pharmacy to fix trauma, or to fix poverty, or to fix other social risk factors? So as a physician, I feel very comfortable in saying doctors alone are not going to solve this, right? We need community-wide approaches, but physicians do have a role, and I think we've been neglecting the full extent of that role that we could be pursuing. So I do see, again, high rates of addiction and alcohol and drug use associated with this, as well as higher rates of suicide. And again, the approach that we've taken obviously has not been working. And I think we see this now across other populations. We're seeing more addiction, more overdose deaths. I wonder how many of those overdose deaths are actually suicides that maybe we're not counting as suicides. I also observe, I haven't seen it well characterized in the literature, but in my own experience working with patients and in my own family, there's almost a passive suicidality where someone's not actively looking for means to kill themselves, but they don't care whether or not they survive. And that has a huge impact on health behavior. And I think we're not picking up people who are at high risk for these issues. But what we also recognize is that these types of risk factors lead to more chronic disease. And quite frequently, the patients who are suffering chronic disease, physical health outcomes, are also at risk for suicide, but we're not screening adequately for that risk. The other thing that we observe across the lifeline is adverse adulthood experiences. And this is not well described in the literature either. We do know a lot about toxic stress. But there is a lot of toxic stress right now in our society. Toxic stress related to political fights, toxic stress related to financial considerations, toxic stress related to racism. Are we post-racial America? Well, no, I wish we were, but we're not. Racism is alive and well. If you look at some of the outcomes related to what happened at Standing Rock, how dare they wanted to protect the safety of their water, but the racism that came out of that was tremendous. That has an impact on people. My own children were asking me, Daddy, why do they hate us? My own child asking me this. So we need to think about this also from a more societal perspective and recognize suicidality is not in a silo. It is integrated into all aspects of society, including medical care. But we haven't done a good job of recognizing this. But I'm very encouraged with what we're doing in North Dakota to look at this as a zero suicide state and recognizing that we all have a role in addressing this crisis. The other challenge that I see when people grow up with adversity, whether it's in a boarding school or just with a lot of dysfunction within the home, what have they learned about parenting skills? Do abused children eventually have children? Absolutely. So what do? We incarcerate, We point the finger, but we don't intervene very well. And there's some very promising studies coming out of California looking at home visiting programs combined with parenting skills training as being much more effective way to improve and promote health during childhood that then links to long-term improved outcomes. One of the little-known facts here in North Dakota, looking at average age at death, it's 75.7 years in the white population, 54.7 in the American Indian population. 21 years difference in average age at death. That's third world health conditions. And I'd like to remind my colleagues in public health that you do not have to cross an ocean to find third world health conditions, right? It's right here, just right down the street in our reservation communities. So we have a lot of work to do, and much of this, if we look at the leading causes of death among young people, particularly in American Indian populations, it is suicide. So we have a lot of work to do, and I wanted to really frame the disparity from a social determinants of health perspective and recognizing that there is a role for clinical care, but it's one piece of a bigger picture. So I've seen very good suicide prevention strategies, some community-based programs, like many of you may have heard of Family Spirit. And it's a home visiting program that's linked to parenting skills, but also culturally rooted in traditional parenting practices. Very healthy, very holistic, very culturally relevant. And it does include things like home visiting. From a policy perspective, do we reimburse community health workers in North Dakota? No, we don't. So when we link these issues in a broader sense, we also have to look at the policy implications. Community health workers who are doing this type of work are reimbursable under Medicaid all the way over in Minnesota, but not here. So there are considerations that are linked to policy that we need to consider as well. In addition to that, I've seen some very successful programs that they're doing other cultural interventions like equine therapy, looking at integrating care of horses within young populations. And it's remarkable the outcomes that we see with autistic populations, with addicted populations, with young people who are dealing with adversity. One of the reservation communities in Wyoming that I've worked with, they had the highest suicide rate in the state when they looked at their population. They implemented a comprehensive program including equine therapy, and the assessment showed that the students, the young people, responded best to that component of the program. They wound up going over 3 years without one suicide by having a comprehensive community-based approach. So these things can work. We just need to recognize that they need resources. School-based approaches, I'm so happy to see what we're doing with Sources of Strength. I think that that's another really meaningful approach. And we have to have interventions, whether it's in the places of worship, whether it's in the schools, whether it's in the communities, but it also needs to be in our clinics. And again, one of the outcomes of adverse childhood experiences and unresolved trauma is not just suicide risk, but also physical health challenges. And on one of the slides that Alison showed earlier, 22% of people who had committed suicide had physical health outcomes as a result of their suicide risk. So what we see is a lot of people engaging primary care medicine, going to the medical clinic, but they may or may not be plugged into the behavioral health system. So we have a huge opportunity if we can integrate zero suicide into our medical care. We need it in places like Prairie St. John and mental health services, but it needs to be in primary care medicine as well. We need to have a much more comprehensive approach. So what is zero suicide? And I'll kind of go into each of the components, not in a great deal of detail, because again, this is more like a 2-day training to get the full understanding of the system. But there's several components linked to zero suicide, as you can see: lead, train, identify, engage, treat, transition, and improve. And I'll go into a little bit of detail in each of those steps. But it is a very holistic approach. So zero suicide actually started in behavioral health. So it was actually initially rolled out in behavioral health practices. And the goal was to keep people alive so they can experience recovery. And focuses also on error reduction in healthcare. And it's remarkable how we take universal precautions for things like handling blood samples, right? We think that there might be risk for a bloodborne illness, so every time blood's drawn, we wear gloves. That's part of what we do. suicidality is more common than bloodborne infections, but we don't take universal precautions for suicidality, right? That doesn't make any sense. And it doesn't cost a lot to actually take universal precautions and actually screen for these issues. So we have to look at improving our systems of care in the healthcare environment. And people like me, primary care doctors, need to have a role in expanding, identifying people who are at risk. So zero suicide, there was a brief mention of the National Strategy for Suicide Prevention, and that's actually included. Zero suicide is now a component of this national strategy. And there's a framework for systematic clinical suicide prevention in behavioral health and healthcare systems. So looking at how we can be more intentional about identifying people at risk. And there's a lot of information on their website. If you go to zerosuicide.com, you can actually download a lot of these tools, and a lot of the presentations are available at no cost. A lot of this was funded through SAMHSA grants, and they want to expand the outreach of what they're doing with zero suicide. So what is different about this program? Suicide prevention becomes an accepted component and core responsibility in healthcare. And what better place to do that than North Dakota, where we have increasing rates of suicide, but we don't have yet a comprehensive way to address this in the primary care settings. And if you look at the health professions shortages that we have tremendous shortages in behavioral health, also tremendous shortages in primary care. But in truth, we have more primary care providers than we do behavioral health providers. So the opportunity to identify people at risk is also in that setting of primary care medicine. So it's not just the role of behavioral health. Also, part of what's different is continually applying new knowledge. So it's not static, that each of those components can be improved over time as we develop new evidence-based practices. And it's a systemic approach that involves everyone on staff, not just the providers, but every component of the healthcare system can have a role in identifying people at risk and having an impact. So why is this important? A recent study showed that 45% of people, so nearly half of people who died by suicide, had been in contact with their primary care provider in the month before death. Isn't that remarkable? So when we think about all of the associated chronic health conditions that we see when people have unresolved trauma, quite often people are addressing the physical needs, but may or may not be plugged in to mental health programs. So it's a huge missed opportunity if we're not actively screening for people who are at risk in the primary care setting. So again, when we look at older adults, so populations that are elderly, that have even more chronic disease issues, over 70% of them had seen the primary care provider within the month prior to that. So is that an issue in North Dakota? Do we have an aging population? Do we have a rural population? So I think this is a real opportunity. When we look at the population who had died by suicide, it was only 19% who had seen mental health services in the month prior. So what this is telling us is that a couple things. One, hopefully the people going to mental health services were having lower rates of suicide. But it's also telling us that in the primary care setting, we're missing a big opportunity. So addressing suicide in healthcare systems is an important issue, and what do we do about it? Well, one of the programs that's adopted this now for over 15 years is the Henry Ford Health System, actually in Michigan. And you can see the numbers of suicides that they had per 100,000 patient population. And they've dropped in some years to 0 across their whole system, because every patient now gets screened for suicide risk. Every positive screen gets a warm handoff to someone who can actually create a prevention plan. So every patient is engaged around this and becomes part of the culture of healthcare. We see this in aspects of medicine now. I know every time I go to the primary care doctor, I'm always asked, do I feel safe at home, right? You know, and I do, fortunately, but we're asking these types of questions related to things like risk for domestic violence. We're asking for risk for addiction and whether or not we use substances. So why not look at high risk for suicidality and major depression? So again, looking at this model, it's a very holistic approach, and I'll go through each of those components, but it is integrated and each component is interdependent on the other. We've now rolled this out in a number of tribal communities, both through tribal programs and Indian Health Service federal programs. And one of the things that I think our communities respond well to is that it is a holistic approach, and it's very consistent with some of our traditional beliefs. For example, in Lakota, we look at health really as being balanced among 4 forces: spiritual, mental, physical, and emotional. And when I think about my own training as a doctor, what's another word for doctor? What do we call ourselves? Physician, exactly. So we're saying on the front end, as a physician, we're dealing in the physical arena, right? Physician and physical have the same Latin root, physic, which means the natural sciences. So if we're just physicians and only addressing physical outcome of disease, we're not really being healers. We're not really addressing the issues that our people are dealing with. And in traditional medicine, we would look at each of these components as being equally important: spiritual health, mental health, emotional health, and physical health. And I think in modern times, we tend to compartmentalize these a great deal. It's interesting, in my own experience with traditional medicine, spirituality is incorporated into what we do. When I did my residency in family practice, the only time the word spirituality came up was when I was doing my hospice rotation. So we had to wait until there was an impending death before we even dare say the word spirituality, right? That's outside of our arena as physicians. Well, it may very well be outside the arena of a physician, but it's not outside the arena of a healing system. A healing system needs to recognize that imbalances in any of these arenas can lead to suicidality risk, right? So we have to engage everyone. Places of worship, schools, how we're dealing with our relationships and having community-based interventions, and certainly clinic-based interventions as well. So in thinking about this, why is this relevant to American Indian Alaska Native communities? And again, when we look at the shortage of mental health providers across North Dakota, it's a terrible shortage. It's even worse in our tribal communities. We don't have a lot of psychiatrists working in Indian Health Service or tribal programs. And we have a terrible shortage of even substance abuse counseling. You know, there's a terrible shortage of providers across that whole continuum of mental health care. But we do have clinics, and we do have opportunities to identify people at risk. And I love this from the Hunkpapa Lakota leader, Sitting Bull. Sitting Bull College is not too far from here, but he said, "Let us put our minds together and see what life we can make for our children." Let us put our minds together and see what life we can make for our children. And I would put forth that that's for all of us, not just tribal populations. In Lakota, we say mitakuye oyasi, which means we are all related. And we believe this. We are all connected. The components of being a human that connect us together are much stronger than those issues that divide us. And when we think about this from a holistic perspective, I think we have a lot to learn from each other in terms of medical science, but also a lot to learn from each other in terms of being more holistic in our approach to each other. And that's one of the things I really appreciate about Zero Suicide. So the first component is LEAD. And again, you can download this information from the Zero Suicide website. But it's very important to have good leadership to recognize that we have to have buy-in from the leadership of the organization. So it's great to have the CEO here talking about their approach within their components. So it's not just the providers that need to know this, it's the leadership as well. So leadership has to make an explicit commitment to reducing deaths by suicide. And I think that we're taking some meaningful strides looking at our health systems, looking at our payers, and how we can incorporate a better approach to identifying people at risk within our health systems. You know, one of my roles as Associate Dean at the medical school, what I really want to do over this next year is we need to incorporate Zero Suicide into the medical school curriculum. We need to incorporate it into the Master of Public Health curriculum. We need to go further upstream. So this is just a normal part of what we do in healthcare. It shouldn't be something that's seen as an offshoot or a side component or a different silo. This really is integrated in a meaningful way. Also, the organizational culture focuses on safety of staff as well as patients. And also we look at loss survivors and as active participants. So what many of the programs have done around the country is incorporating people who are survivors and being a part of the leadership team to share their stories and to show how this really is a real issue that needs to be addressed. Then there's a development of an implementation team. So the leadership, obviously at the CEO level, chief medical officer level, there has to be buy-in. But there has to be a way to ensure that we orient all staff within a clinic, that this is an important component. There's a work plan, and there's templates on the Zero Suicide website for developing a work plan and how to address gaps, and good surveys to conduct with staff to see where the gaps are from the providers and staff perspectives. What we've seen in terms of successful implementation teams, once there's leadership buy-in at the highest levels, there needs to be representative from executive leadership that's an ongoing participant to show that this is a vital component of our clinical system, but also that there is meaningful participation at the highest levels of leadership. Also, well-regarded clinical leaders. We have our formal leadership within organizations and informal leadership. I think that's true in any organization, whether it's medical or non-medical. But having champions within the medical staff is another vital component. And I think in family medicine, many of us are trained to try to think more holistically. And I think we have the opportunity to develop more clinical champions for zero suicide within clinical settings. Again, attempt and loss survivors as part of the team to share that real-world experience. Performance improvement and IT staff. There's some very good electronic health record programs that have been developed that can be incorporated to include zero suicide. So once you have your implementation team and leadership, the next stop is for training to make sure that everyone has a baseline level of understanding of the zero suicide approach, but also its importance within the clinical setting. So the employee assessment and training, each employee is assessed for their beliefs, training, and skills associated with suicide. And it's remarkable, we still have people who believe if you ask about suicide, you're going to encourage someone to commit suicide. There's still people who believe that. It's remarkable to me. We need to get that out, that whole thought process out of clinical care. And maybe that's part of our role in the medical school. Let's make sure that we understand at the front end, before we even see a patient, we know that this is not going to lead to more suicidality just if we ask about risk. But in our evaluation of self-assessments, there's still that belief. I'm afraid to ask about it because it might encourage someone to start thinking about suicide, but we know that that's not the case. All employees, whether they're clinical or non-clinical, have to have some degree of assessment and appropriate levels of training. Quite often, people who are working at the front desk might identify behavior or a characteristic that's unusual that needs to be a part of our program to assess people who are at risk. So there's a workforce survey. I'm so happy to see the Veterans Administration here. I know that there's been expanding interest in incorporating the workforce survey and also zero suicide into many of our Veterans Administration facilities. Another population that's at very high risk for suicidality, who may be engaged in the physical aspect of healthcare, but maybe not the mental health services. So I think Veterans Administration is another key population and a provider system to look at zero suicide as a meaningful intervention to try to reduce our disparities here in North Dakota. So once you do that assessment, the next step is to identify. So how do we identify people at risk? There's actually very good screening tools that can be done by the patient and can be incorporated into the electronic health record. So it's not a high level of time or effort or resources that need to be put into initial screening. So screening tools can be done at the front end when people are filling out their paperwork, or even looking at some clinics are using kiosks to implement their information that goes directly into the electronic health record. And this type of a screening tool can be incorporated into that. I'm sure many of you are familiar with the PHQ-9. It's 9 questions related to mental health, primarily trying to assess for depression. And each of those 9 questions, you can get a score of 0 to 3. So within the PHQ-9, your score can be 0 to 27. And it's been proven to be very sensitive and specific. If your score is 10 or greater, it's 88% sensitive and specific for major depression. Very powerful tool. The 9th question, as a standalone question, has been proven to be a valid tool to screen for suicide risk. So the 9th question of the PHQ-9 is, over the last 2 weeks, how often have you been bothered by thoughts that you were better off dead or of hurting yourself in some way? And the score is 0 to 3 is not at all, several days, more than half the days, or nearly every day. That question alone has been proven to be a valid screening tool for suicide risk. So one of the interesting things and why you need IT involved and the electronic health record involved is that some of the clinics that I've worked with, they would record the score for the PHQ-9, questions 1 through 9, but not specific to which question they were scoring. So if you get an overall score of 8, you know there might be some risk, but what if the score was 3 on this question? That is a clear indicator that might not be reflected in the entire PHQ-9. So that's why, again, IT is a component of this too. You have to have your electronic health record to be more specific to look at this particular question. Now, this is not diagnostic. This is a screening tool, and there's multiple follow-up questionnaires that can be better at diagnosis. And there's a Columbia Suicide Severity Rating Scale. I've seen many places incorporate this. And then again, there's pre-packaged electronic health record opportunities to plug this into the EHR. So if you're asking those questions, it could be the PHQ-9, it could be just the 9th question if that's what you choose to do. Then you can have an automatic way to go to the next level of screening and actually have a warm handoff and train your primary care personnel, the nursing staff, the medical assistant staff on how to do that warm handoff to make sure that we're doing it effectively. And every place that's incorporated this has seen significant improvements in identifying people at risk and getting them plugged into services. But I wasn't trained in this when I went to medical school or when I did residency. We weren't trained to screen for depression or suicide risk. And it was in my own experience seeing patients with diabetes who were very depressed and who were self-medicating with alcohol or other substances. And it made me realize that we're just inadequate at addressing this if we're only looking at physical health within its silo. Because the mental health issues have a direct impact on how well we control blood sugar, for example, or blood pressure or heart disease. So it's vitally important to look at this in a more holistic way. And I think the zero suicide model has an opportunity to help us with that. So now that we've identified people who are at risk, what do we do? How do we actually address that? And how do we engage with the populations? So the next step through engage is safety planning and means reduction. So there's sample safety planning that are available on the website that you can download from Zero Suicide. And then also looking at means reduction. So for safety planning, there can be warning signs, looking at internal distractions. So in this whole setting, even the idea of mindfulness is important. And what we think about has a direct impact on our physiology. You know, if we looked at mindfulness and the studies that look at being mindful and conscious of things that we're grateful for, that changes our physiology. If it were in a pill form, someone would get a Nobel Prize in medicine, right? But since it's not a pill, it's our own mindfulness and our own way of thinking, our own way of processing, then it's seen as alternative medicine. So there's a whole sector of my fellow physicians who don't regard it as well as they should. But if it was in the form of a pill and it was that effective, that would be remarkable. And we also can't make assumptions about what people might want to do. There was a great story, one of the programs that has incorporated this, actually in West Virginia. The providers said, what do you do for your own well-being? And it was a man who was in his 70s, lived alone, very kind of gruff, rough-looking older guy. And he did yoga. That's what he actually enjoyed it. So we can't assume that we know what people will do just by their appearance or by their demographics. So we have to recognize that there's all kinds of internal strengths that we could maximize. And Zero Suicide provides us an opportunity to at least identify those opportunities for internal, they say distraction, but really it is internal refocusing on wellness. External distractions, social support, I really believe that, again, social isolation has been one of the huge risk factors for all kinds of poor health outcomes, and that needs to be incorporated. And when thinking about my own training in medicine, and I was very fortunate, I went to Stanford University for my medical school training, very good medical school. We didn't learn about these things. We didn't learn about social connectedness and the importance of social connectedness in health outcomes, even though we know in all kinds of health issues, even in cancer, people who have strong social connections survive longer than people who are socially isolated. It's true across the health system, and we need to do a better job of identifying those things. Also, for lethal means reduction, I really did appreciate the slide that it's not all firearms, right? It's a little over half. But in tribal populations, it's actually hanging is the most common. So what do we do about means reduction? How do we identify all of those risks? And quite often, if a person has a plan, they will be thinking, there's that piece of rope in the garage, or there's that extension cord, the orange extension cord on the shelf. They actually have a specific plan in place. And if you identify that, you can remove it. So it doesn't remove entire risk, but at least we're identifying what the individual is thinking about. So it's actually a deeper dive trying to understand what the patient's process is for lethal means and how can we reduce that. Then, of course, a suicide care management plan, and much of this is available on the website. And I apologize for going through these things relatively quickly, but again, it's about a 2-day training we're condensing into the hour here. But hopefully, you'll each have a chance to look at the website and identify some of the tools. But part of Engage does include a suicide care management plan that's then incorporated into the treatment at the clinic perspective, but also can be directly put into the electronic health record. And I'd love to see this as a statewide initiative. We have North Dakota Health Information Network. Maybe there's a way we combine our efforts to try to incorporate this type of programming into it. And it's not highly expensive. It's not resource intensive. These are things that are basically just connecting with our patients and talking to them and meeting them where they are, and not being afraid to talk about things like suicide plans or lethal means. We have to get beyond that. And again, I think the training for our medical providers needs to start earlier, and that's on people like me who are educators at the medical school. We need to do a better job. So then for treatment, there's all kinds of evidence-based practices that are effective for treatments. If you, again, go to the Zero Suicide website, there's evidence-based care models that can be explored. There's been randomized clinical trials that have been studied in multiple populations. I won't go into detail in each of them, but I'm sure many of you are familiar with dialectic behavior therapy, cognitive behavioral therapy for suicide prevention, collaborative assessment and management of suicidality, and others. And these are well described in the literature, and they're compiled in the Zero Suicide website if you look at the treat component. And then transition. What happens if we diagnose something in the clinic? How do we ensure that they get plugged into appropriate services? So on the front end, we have to ensure that people get timely access to interventions, and to ensure that, whether it's medical treatment or ideally combining methods to include the different types of cognitive therapies and counseling as well. And then finally, improvement. How can we continuously improve our approach to suicidality? And that's where we have to have ongoing participation, genuine engagement from our administrative leadership and clinic staff to ensure that we're focusing on quality improvement and evaluation of our programming. And then we should be collecting data on this to make sure that we are seeing positive outcomes, and if we are not, identifying where the gaps are and what we need to do to continually improve. And just from my perspective, thinking about this, there's so much available to us at no cost that we can just download. But thinking about this, we have to make sure that it's a priority across systems. So I'm just very pleased and honored to be given the time to have this discussion with all of you, because each of us works in different arenas, whether it's Indian Health Service, tribal programs, Veterans Administration, mental health care, and the private sector. There's so much that we could do in the clinical sector to make a meaningful impact. And when I think about the preventable suicides, there's been some criticism of the word zero suicide. It's setting the bar too high. And then the question we always ask as trainers is, how many suicides are acceptable to you? And it should be zero, right? This is preventable. And zero suicide as a clinic-based intervention is one component of a broader initiative that needs to include the communities, the places of worship, the schools, and genuine community engagement. But there's so much we could do with built-in electronic health records and clinic staff that could be trained to do this. Again, I'm a trainer for zero suicide, but if you want additional information, Chelsea Booth is available for general information. We could get her email address somehow plugged into the coalition. And they do have a specific person who's the tribal lead for Zero Suicide Institute, Sadie Ali, and she's more than happy to share additional information. And I'm happy to share these slides as well if people want to download those and more useful resources. So just in terms of closing thoughts, when I think about the issues that we're facing, so much of it is preventable. And I always like to tell a traditional story about how we approach health within tribal populations in this region. And it's a story of three sisters walking along a river. And as they're walking along the river, they see babies and young children in the water struggling to stay afloat. So the first sister jumps in and says, this is a crisis, it's an emergency. We need to get the babies out of the water right now. I'm sure a lot of us do crisis management and can relate to that type of thinking. The second sister says, no, we need to teach the babies how to swim so they can survive while they are in the water. And the third sister keeps walking upstream, and her two sisters get angry with her and say, where are you going? Why aren't you helping us? And she says, I'm going to find out who's putting these babies in the water, and I'm going to stop them. And that's public health. That's genuinely preventing issues before they become a crisis. And each of us has a role in that, whether it's in law enforcement, in primary care medicine, in public health, in mental health. I think all of us have a role in identifying people at risk. And this is one tool that can help us move in that direction. Thank you all very much for your time. So I did leave a few minutes if there's any questions or comments or rumors, innuendos, tall tales. No. Yes, I'm happy to share the slides, and you can, if through the website, through Alison or however we can. I'm happy to share the slides. Plus, it has all the links to the resources that are available online as well. Yes. Yeah, so there's been, this has been implemented in a lot of health systems around the country, and they are showing drops in suicides in those populations. So if you look at the population as the active users of that clinic system, we have seen drops in suicides in those populations. Really wonderful outcomes, yeah. But I know we have is there, oh yes, go ahead.
Oh, thank you, Alison. Hello. There's been some success with setting up workshops and places where older individuals can go to work on fixing woodworking things or working on electronic type of projects. Do you know of anything happening like that in the state, or maybe being addressed with healthcare providers that work with the geriatric population about just helping people find more purpose and finding more social interaction outside of their day-to-day?
Yeah, and each community is different, so I think the resources available in each community varies quite a bit. I haven't seen a comprehensive statewide approach to that, but I think it's vitally important, particularly in North Dakota, where we do have an older, more rural population. So part of our community-based approaches and what we need to develop and implement and evaluate includes building social connectedness within populations. And each community would have a different approach, culturally or based on the demographics, the resources within a particular community. But I think anything that we can do to build opportunities for social connection will be good, not just for reducing suicide risk, but promoting wellness in general. That is an important part of who we are as human beings, is our social connectedness with one another. And whatever we can do to promote that is vitally important. But I have not seen a comprehensive statewide approach to that, but maybe that's something that needs to be part of the discussion. Has anyone else seen that as a comprehensive? Nope. Okay. Yeah.
Just one quick comment on that. We have had some of our Source of Strength team make connections with elders. Like they'll actually, thank you for being a Strength in My Life card, write a card to an elder, go give them that, and then maintain some ongoing contact. And we talk about just one of the strengths is being a mentor, having elders, somebody older in your life is being really protective. But as you become elderly or an elder, having children in your life is protective. And there's a lot of we've seen some really nice both in our some of the tribal communities, some of our rural communities, and even in some large schools where they've really kind of built that into some of those contacts that they're doing, not just peer-to-peer messaging, but they're also going to kind of that cross-generational stuff. So.
Yeah, that's a very good comment, and I agree that I think there's even more opportunity to build that intergenerational connectivity, and it's good for the elders to connect with young people. It's good for the young people to connect with elders. There's a lot of cultural considerations there as well, but also in my own practice, I remember working with an elder woman who was trying to quit smoking, and no matter what we did with health education, it wasn't until her granddaughter said, "Grandma, please quit," that she finally did. That connectivity and the power across generations really has a meaningful impact across multiple areas of health. And I think just wellness promotion could be promoted by encouraging this type of social connection. But very good point. It should be across generations as well. So thank you. All right. Remember the Phil Donahue show? That kind of reminds me of the running around with the microphone.
You've mentioned a lot about the importance of teaching at the universities and teaching medical professionals, but is there still a lot more that needs to be taught in society on to avoid the stigma of mental health care in general? Is that something that we're still seeing? And what relation is that, especially in relation to depressive disorders related to suicide and being able to, they have suicidal comments or suicidal thoughts, are they ashamed or unwilling to bring those to their spiritual leaders, bring those to their medical professionals that they're dealing with, and how can we do a better job of reaching out to them, both in the medical profession, but also within our spiritual communities and faith communities?
Yeah. Excellent question and very good point. And we do see it quite a spectrum. There are those who are comfortable sharing with what's happening in terms of mental health, and those who are ashamed or feel like it's a sign of weakness. We still see that perspective as well. So we have a lot of work to do, I think, in terms of raising awareness and decreasing stigma. And unfortunately, our system in many ways has kind of blamed the patient or blamed the victim for many years. We have to get over that. So I think training providers while they're still in school is an important component to that. But also I think things like sources of strength are tremendous when we could include entire schools and that peer support and recognizing that it's okay if someone feels imbalanced, even if it's mental or emotional, spiritual imbalance, that it's not a sign of weakness. It's not something that's negative about the character of who they are. We all deal with these challenges. And I think that the more we could do in the communities and in the schools at a young age to try to get rid of the stigma, the better. So I'd love to see those things continue to expand. Yeah.
Thank you for sharing your thoughts and information on this. You talked about the screening questionnaires that are used, and we're kind of exposed to those on our doctor visits and stuff. And that's seems like a quantitative assessment of mental state. Are there any trainings for assessing behaviors? Because a lot of people who are seriously thinking about suicide could easily lie on those questionnaires, and they would go unnoticed.
Yeah, that's a big challenge, is with the things that are self-reported, if someone's not being honest with those responses. It is remarkable the numbers of people who will be honest, though. So it's not, there's no screening process that's 100% effective. Even for screening for cancer is not 100% effective. But on the balance, if we're at least doing the screening, we're going to identify more people than if we're not doing the screening. But you are correct. We can't look at any of this as being 100% effective every time. But we can certainly identify a great number of people who are at risk. Because it is amazing how many people are completely honest when they're filling that out, particularly if they're doing it on their own. They're not being asked the question. They actually can fill it out on their own. We've seen people can be tremendously open with that. But yes, some people will not report these things too.
Assessments or behavioral things to notice. I'm also asking from the perspective of an educator. Like, if I have students in my classes, I won't be, they won't be going through some of these questionnaires, but there might be things that I could notice and be proactive about. So. There's some preliminary work, and one of the slides that Alison showed earlier is the other signs that are potential for risk of suicidality, including issues with relationships or physical health or job performance, those types of things. I haven't seen good tools yet that are developed to address that, but that's a wonderful idea. Maybe we need to develop and test interventions that are beyond just the quantitative side. Sure, thank you.
Maybe one last.
Last question.
Yeah.
I think one of the things you'd said earlier about training people, tying that in with the screening tool, just having the tool itself is not the answer. I can think of a time I worked for Sanford and I had a dermatology appointment, and the person who gave me the initial suicide question was, "You're not suicidal, are you?" And so you think about what's behind that. What's behind that is the perception that the question is an inconvenience, probably some fear and discomfort with the question, and what do I do if this person asks, or if the person answers in the affirmative direction. So I think that's one of the other nice things about Zero Suicide is you get to take an inventory and explore what people's beliefs are, because that's an essential part. Otherwise, it just seems like a check the box, here we have this screener, and then you have a lot of people using the screener that may or may not know what to do with it.
Yeah, but that's a great point. What are those next steps, and how do we actually engage and intervene? So very good point, but I know we're, okay, one more.
Last one.
Well, and this is just a comment, and I do believe in my heart that some of the stigma is generational, and we may see that stigma die off as we see generations die off. Yeah. Unfortunately, I hate to say that, but I do believe that we're starting to educate the kids in school. Sources of strength, things like that. I think we're starting to talk about it more, and so it will become something that's okay to talk about as a generation or so passes.
Yeah, well, what a beautiful vision for the future. So, great way to end. Thank you all very much.
Thank you.